All right, let's just dive right into this explainer and systematically break down one of the most vital but honestly kind of confusing tests in acute care, the blood gas printout. Whether you're running around a bustling ER or managing acute patients up on the ward, understanding these numbers quickly and accurately is literally a superpower. So we're going to build your confidence up step by step. You know the feeling, right? We've all been there. You're holding that tiny piece of receipt paper covered in an intimidating string of numbers, just trying to make sense of what the patient's body is actually doing. Well, today, we're transforming that chaotic list of values into a crystal clear, logical diagnostic checklist that you can use the second you walk into your next shift. No more guessing, just structured, highly efficient interpretation. Okay, here's our roadmap for this explainer. First, the basics of oxygenation. Then, hemoglobin and oxygen capacity, decoding acid-base balance, anion gaps and compensation, lactate and electrolyte clues, and finally, some crucial clinical pro tips. Let's get to it. Section 1. The basics of oxygenation. Okay, before you even look at a single gas value, you've got to take a step back. I know it sounds basic, but you have to make sure the data you're about to read actually matches the clinical reality of the patient sitting in front of you. Confirm the name, the date, the time, pull up any previous blood gases to compare, and absolutely crucial here, note the clinical state of the patient and exactly what oxygen delivery device and flow rate they were on when that sample was drawn. Context is literally everything. So there's actually a super simple mathematical trick for checking the partial pressure of oxygen, or PaO₂. On room air, a normal PaO₂ sits above 10 kilopascals. But what if they're on oxygen? The rule of thumb is that the PaO₂ should be roughly 10 less than the inspired oxygen percentage. So say your patient is on 2 liters of oxygen through a nasal cannula, which delivers about 28% oxygen. Their PaO₂ should ideally be above 18 kilopascals. If that overall PaO₂ drops below 8 kilopascals, regardless of the setup, that patient is officially in respiratory failure. Now, we divide respiratory failure into 2 main camps. Type 1 is mostly a ventilation-perfusion mismatch. Think of a pulmonary embolism, right? The ventilation is fine, but perfusion is blocked. Or think pulmonary edema. Here, the oxygen is low, but the carbon dioxide stays normal. On the flip side, type 2 respiratory failure happens when reduced lung ventilation causes PaCO₂ to rise above 6 kilopascals. A really easy way to remember this. Type 2 has 2 gases affected. The oxygen is low, and the carbon dioxide is high. Section 2. Hemoglobin and oxygen capacity. 200. This number is honestly staggering. Carbon monoxide binds to hemoglobin 200 times more strongly than oxygen does. It creates carboxyhemoglobin, which physically blocks oxygen from being transported. Normal values are usually less than 3% in non-smokers, but in smokers, it can shoot up as high as 15%. This is exactly why a level of just 10% can trigger headaches and hidden hypoxia in your patient. You've always got to check these variants. Section 3. Decoding acid-base balance. All right, I need you to just lock these 3 normal ranges into your brain right now. pH, that should be between 7.35 and 7.45. Partial pressure of CO2 should be sitting between 4.5 and 6 kilopascals. And bicarbonate should be right between 22 and 28 millimoles per liter. Why are these so important? Because comparing these specific numbers is exactly how we figure out if we're dealing with a primary respiratory problem or a primary metabolic problem. Remember, a pH below 7.35 is acidemia, above 7.45 is alkalemia. So the real trick here is understanding how these components actually interact. Carbon dioxide forms carbonic acid in the blood, meaning more CO2 equals more acid. But bicarbonate? Think of bicarb like a giant sponge. It's an ion that literally mops up those acidic hydrogen ions. So it stands to reason a higher bicarbonate level equals less acidity in the blood. If the CO2 is out of whack, it's a respiratory issue. But if the bicarb is off, you're looking at a metabolic issue. Section 4. Anion gaps and compensation. Okay, the anion gap. It sounds complicated, but it's simply the difference between the positive and negative ions in the blood, calculated as sodium minus chloride and bicarbonate. The normal gap is roughly 4 to 12 millimoles per liter, mostly driven by normal unmeasured albumin. But if this gap is higher than 12, that is a massive red flag. It suggests some rogue unmeasured substance is causing an acid buildup in the blood, like ketoacids in a patient with diabetic ketoacidosis, for example. So what exactly are those rogue substances? Well, the classic medical mnemonic mud piles is incredibly useful here for systematically recalling the specific causes of a high anion gap. We're talking about toxins like methanol or salicylates, ketones from DKA, or renal issues like uremia. If you've got a patient with a high anion gap metabolic acidosis, one of the mud pile suspects is almost certainly your culprit. But wait, what if the anion gap is perfectly normal, but the patient still has metabolic acidosis? Well, in that case, you've got to think about gastrointestinal or renal losses of bicarbonate. The body is literally losing its sponges. And this is perfectly captured by the hard-up mnemonic, covering things like severe diarrhea or renal tubular changes. Now keep in mind, the body is smart. It actively fights to normalize the pH. We call this compensation. But the speeds of this compensation are vastly different. Your lungs, they can provide respiratory compensation almost immediately by just increasing or decreasing ventilation to adjust carbon dioxide. But metabolic compensation, that requires the kidneys to adjust bicarbonate levels, and that whole process can take several days to fully kick in.
Section 5. Lactate and electrolyte clues.
Lactate is a perfect example of this. It's a byproduct of anaerobic metabolism, right? So a high lactate basically screams that the body's tissues are starved of oxygen, often a major red flag for hypoperfusion and sepsis. Plus, if you just quickly glance at the included blood glucose and electrolytes like sodium and potassium, it can instantly explain a patient presenting with seizures or a low level of consciousness. Don't just stop at the oxygen and pH. You gotta mine the bottom of that printout for these hidden clues. Section 6. Crucial clinical pro tips. All right, pro tip number 1. Arterial stabs, they hurt. They're painful, but you can often spare your patient, like say a COPD patient on non-invasive ventilation, all that pain by just using a venous blood gas, or VBG. Why? Because the venous values for pH, lactate, and bicarbonate are highly accurate and surprisingly close to the arterial ones. Just remember, the oxygen levels are not going to correlate, but for acid-based monitoring, VBGs are a fantastic, much less painful tool. Pro tip number 2 is actually a massive warning. You absolutely must ensure that all of the air is removed from the syringe when the blood is drawn. If you leave even a tiny little air bubble in the syringe with the blood, the gases from that air will diffuse into the blood sample and just completely invalidate your hard-earned results. It's such a simple mechanical step, but forgetting it ruins the entire test. Pro tip number 3. And honestly, this might be the most life-saving piece of information in this entire explainer: the asthma trap. If you see a quote-unquote normal carbon dioxide level in a severely asthmatic patient, do not be reassured. You need to act fast. An asthmatic should be hyperventilating and blowing off huge amounts of CO2. So if their CO2 level is creeping back up to normal, it means they are exhausting their respiratory muscles. Their ventilation is dropping, and they are likely heading straight toward respiratory arrest. And that really brings us to our final thought. If a perfectly normal-looking number on a tiny piece of receipt paper can silently predict an impending respiratory arrest, what other vital clinical clues are hiding in the numbers we just gloss over every single day? By mastering this systematic approach to blood gases, you've taken the first massive step in uncovering those hidden clues. Take this structured approach, apply it to the very next gas printout you see, and just watch how much more clinical reality you uncover.